Good morning, good afternoon, and good evening to all the urology trainees joined in our YouTube channel all over the world. Today we are entering into episode 62 of our urology exam preparation. We are going to do a mock viva on renal tumor scenarios. We have a trainee. Thank you for joining us.
Thank you, Mr. Dhanashekhan, for having me.
Okay, your time starts now. You have a 68-year-old gentleman presented with visible hematuria. His flexible cystoscopy was normal. How are you going to evaluate him further?
So I will review this patient in my one-stop hematuria clinic, ideally with the results of his urine dip, observations, body mass index, and I'll take further history about the details of his hematuria, whether it's painless or painful, whether it's initial gross or initial terminal or total. Other urinary complaints, including voiding and storage symptoms. Other symptoms such as history of weight loss of appetite, cough, hemoptysis, any pedal edema, any other swellings in the body, any pain abdomen. Then I'll proceed to take further history about his current medications, his past medical history, including ASA status, his prior surgeries, any prior histories or history of radiation to the pelvis for any other cancer in the past, any family history of cancer. I'll proceed to then examine him, and after taking verbal consent, ensuring privacy in the presence of a chaperone, I'll do a general examination first. I'll assess his performance status and go on to rule out any pallor, icterus, jaundice, lymph nodes, and specifically examine his genitalia and do a digital rectal examination. Since he's already had a flexible cystoscopy, which is normal, I will go ahead and request further investigations, which will include urine cytology, a CT urogram, which, yes, I'll make my further plan depending upon the results of these investigations.
Okay. We are going to look into the CT scans. I'm going to share my screen. You can see now.
Thank you.
Are you able to see this screen now?
Yes, I can see the screen now.
Okay. So let us take it from the top. So this is the uppermost cut. We are going from top to bottom. Okay, I can show again. So what are you seeing?
So this is a contrast enhanced CT of the abdomen. I've seen the axial cuts. I would like to first confirm the date and the details of the patient. There is a heterogeneous lesion in the left kidney, mostly in the lower and mid pole. I would like to see the coronal cuts to comment on the size, but from this I can make out that it's around at least 5 to 6 centimeters in size. Apart from this, the lesion, it has central necrosis, and I cannot comment. There is definitely some enhancement of solid components there. So ideally, I would like to compare it with the non-contrast scans to comment on the enhancement. And apart from this, there are no lymph nodes. There is some calcification of the aorta. So my diagnosis here is that this is a left renal mass, T2A N0 MX, and I would like to look at the coronal scans to comment on the renal score as well.
Okay, let's see the other pictures. So this is the coronal cuts. So again, go from back to front.
right? So in addition to my findings, which I described in the axial cuts, there are also some tiny cysts on the right kidney. These appear to be simple cysts. So my diagnosis here is that this is a left renal mass, T2A N0MX. The renal vein seems to be normal. So the renal score here is 11P. So that is my full diagnosis.
What do you mean by renal score?
Renal score is a score which was devised using 5 different components, including the size of the mass, whether it's exophytic, endophytic, the nearness to the pelvic cell system, its location in comparison to the polar lines, and whether it's anterior, posterior, or between the two places. The idea was that it will give us an idea about how difficult it is going to be to do a partial nephrectomy versus a radical nephrectomy, and also whether we can. It's difficult to do a minimally invasive procedure.
Okay, so what are all the components? How are you going to score using these components?
So the size component, if it's less than 4, it's 1. If 4 to 7 is 2, more than 7 is 3. This patient I've scored as 2. If it's completely endophytic, it's 3, like in this patient. If it's partially endophytic and more than 50% is exophytic, then it's 2. If completely exophytic, then it's scored as 1. If it's less than 4 millimeters from the pelvic cell system, then it's 3. 4 to 7 millimeters is 2, and more than 7 millimeters away is 1. If it's completely between the two renal lines, so contacting both the polar lines, then it's 3. If it's touching only one polar line, it's 2. If it's not touching any of the polar lines, it's scored as 1.
Okay.
And anterior posterior is depending upon its position.
Okay. After going through all these pictures, do you have any differential diagnosis for this patient?
So my first differential diagnosis would be a left RCC. My second differential diagnosis would be it could be a cystic RCC, or it could be any other malignancy of the kidney. The enhancement is slightly on the lesser side, but I would like to look at the exact value, so it would even be a papillary RCC.
Okay. I'm just showing the arrows. Let us assume this is the main lesion and with a small satellite lesion and with some signs of thickening of the renal pelvis and PUJ. You can see that it's quite thickened and hyperattenuating. So is there any differential diagnosis because of this finding?
So because of these findings, it is possible that this is a TCC of the left renal pelvis. The other possibility is that it is a left RCC which is invading the pelvic cell system. I would like to confirm this by discussing this in the MDT, and I will go through the report of the radiologist as well.
Okay. The MDT decides in favor of left-sided TCC measuring at least 3.8 centimeters. So how are you going to treat him further?
So I would like to complete my investigations by getting a CT of the chest as well. Now, again, in the MDT, I would like to also discuss this point that there are two options here. First is to do a ureteroscopy and biopsy, and the second is to go ahead and do a primary nephrectomy with bladder cuff excision along with lymphadenectomy. So, I would be more in favor of doing a ureteroscopy and biopsy, as this may even be an RCC, and the treatment would be different in that case. So that's how I'll make a final decision. Okay. I'll be in favor of ureteroscopy and biopsies first.
Okay, is staging shows no evidence of any distal metastasis, and you are planning for ureteroscopy. What is your primary aim and principles for ureteroscopy for upper tract TCC?
In a carefully counseled and consented patient, in terms of, I'll do a left-sided rigid ureteroscopy, and I'll visualize the bladder. I'll start with the rigid cystoscopy. I'll start with the EUA, then do a rigid cystoscopy. Look at the bladder first, because if it's TCC, then it can have field effect. I would need to examine the bladder as well. Then I'll go ahead, place a guide wire in the left PCS, and do a rigid ureteroscopy, wherein I'll look at the ureter completely first, and then followed by that, I'll place a 46 centimeter access sheet and place a left flexible ureteroscopy and take biopsies and come out.
Okay, we'll complete that. Good presentation, but the main thing is please be aware that upper tract TCC is possible in renal tumor table. Okay?
Yeah.
So once you have that in your mind background, you can come to the diagnosis quite quickly. Not necessarily that renal tumor table should have only RCC, chromopop, papillary RCC, etc., clear cell RCC, etc. There could be upper tract TCC also. So this is an upper tract TCC patient who required left-sided nephroureterectomy, presented with visible hematuria and cystoscopy and staging being normal. Nothing wrong in doing ureteroscopy and biopsy because the tumor is not very obvious, maybe because of some inflammatory changes, but you can see that the whole tumor is in the pelvic region and the renal is nicely maintained. There are some hypoattenuating areas, maybe due to this inflammation and necrosis, and the renal pelvis is nicely inflamed. That's why you are getting this hyperattenuated picture. I know it is slightly difficult in the exam scenario, but the other finding is the renal artery and renal vein. You need to be very clear in explaining that. In this patient, the renal vein on the left side is circumaortic, so it is in front of the aorta. Okay, and also in the back of the aorta. So there are two renal veins coming front and back. It's very, very difficult to say this in the exam. I know this because I saw these pictures before, but these are all the findings not expected, but you should bring TCC as a differential diagnosis. Okay, good.
Yeah.
Otherwise, it's quite straightforward. Nephroureterectomy and the role for pre-nephroureterectomy ureteroscopy you have discussed very well. Okay.
Yeah.
Happy for the next scenario? Who is doing the next?
Yeah, I am doing the next one, Mr.
Okay. Your time starts now. You have a 52-year-old gentleman who went for a well-manned clinic, just like master health checkup, and his blood parameters were normal, his BMI was normal. He had a routine ultrasound which picked up 2.1 centimeter lesion in the right kidney. Okay, how are you going to evaluate him?
I will see this man in my 2-week pathway clinic along with the clinical nurse specialist and take the history. And the history I will ask about the hematuria, UTIs, and other risk factors for the upper renal tract cancer, like such as obesity, hypertension, smoking, family history of renal cancers, and then the professions like exposure to asbestos or cadmium. And then I will also take the other histories, general, is fit and well, and is taking any medications, and then I will move on to examination. So my examination will be the focus, abdominal, and in the flank, I will be unable to palpate anything because it's 2.5 centimeter, but I will take the urine depth and urine sample and do the baseline bloods, which will be including FBCUN, CRP, serum calcium, and liver function test. And then I will also take on at the same time, I will organize urgent CT scan of the renals with the renal mass characterizations and take it from there.
What do you mean by renal mass characterization CT? What is the protocol?
So it's the protocol is that it is a non-contrast CT scan followed by the contrast, and the idea is to see the enhancement of the lesion with the pre and post contrast. If there is more than 15 Hounsfield unit enhanced, it is the favor of enhancing lesion in the kidney.
Okay. When the patient attended the CT scan department, when the staff's explaining him about the IV contrast and need for the three-phase renal CT protocol, the patient recollected during his teenage he had a contrast allergy when he need to have contrast due to some intravenous pyelogram for some stone episodes. So the staffs called you to say that there is a possibility he may have IV contrast allergy. What is your plan?
So my next plan will be that in that case, I will organize either MRU or at the same time I will request speak to my radiologist if he can do the contrast enhanced ultrasound scan, which is the giving the carbon dioxide, which will give the most enhancement of the lesion.
What is MRU?
MRE, the magnetic resonance urogram.
Why do you want to do urogram for a patient with suspicious renal tumor?
Because it not only give me the characteristics of the and characterization of the renal mass, but also it would give me the findings of the renal vessels and surrounding structures.
Okay, I'm sharing the pictures. Are you able to see the pictures now?
Yeah.
Okay, so let's go from back to front. Okay,
So
you can see the axial pictures.
so this is the coronal view of T2 enhanced uh, uh, the mass of a coronal and transverse of the both MRI scan coronal and transverse view. So I currently am seeing the transverse view, and on the right side there is some enhancing lesion in the midpole of the kidney,
Mhm.
and on the left I cannot see any such lesions. And also I need to discuss with my radio urologist for further clarification and further information on the renal veins and renal arteries, and then also I need a CT chest, non-contrast CT chest as well for further staging.
Okay, so the radiologist felt this is the suspicious renal lesion, which measures approximately 3 centimeter. This gentleman also has some coexisting renal cyst, which is not significant, and staging is negative. There is no signs of any extra renal metastasis. Opposite kidney is normal, renal vein is normal. So how are you going to manage him?
So I will, after discussing in my MDT, I will see this gentleman along with my cancer specialist nurse, and then I will discuss the options. And my options will be the partial nephrectomy, radical nephrectomy, or the last but not the favorable will be the cryosurgery, cryotherapy, or the radio frequency ablations.
Why
Or,
cryosurgery
or
or
so
radiofrequency is the least favorable for you?
because he's a quite young and fit, healthy person. And if I do the cryotherapy and radio frequency ablation, the chances of recurrence are high, and also the positive surgical margin are more as compared to the radical partial nephrectomy and the radical nephrectomy, and also he needs more extensive follow-up.
Okay, this patient is quite fit otherwise and is eligible for any procedure, and he asks for doctor do me the best procedure which will completely cure me from the disease. So what is your advice?
I will again discuss the options of the partial nephrectomy versus the radical nephrectomy. Give him the pros and cons of the both procedures, and but I will say that the complete curative is the radical nephrectomy. Again, partial nephrectomy there is a chance of positive surgical margins which are not in the radical nephrectomy, but in the partial nephrectomy we can save the kidney and it is a better outcome in the future as well, and preventing the cardiovascular and renal failure in the futures.
Okay, so what will you advise him?
Uh, Again, I will offer him both, but as he want a complete cure and no follow up, then the radical nephrectomy will be the favor. But if he accepts a little bit options of positive surgical margin and follow up, then I will offer him the partial nephrectomy.
Okay.
But my first, according to the guidelines, I will offer him partial nephrectomy.
Okay. Patient agrees for partial nephrectomy. How are you going to prepare him?
So my preparation will be again all the bloods and pre-op workup and well suitably prepared, well consented patients. Then on the theater, WHO checklist, COVID status done, and then he will be on the lateral position and then bridge up, and then I will start with the robotic and sorry, I forgot to give the option of robotic versus open versus laparoscopic. But robotics is the gold standard and without zero ischemia time. And the process starts with the mobilization of the bowel and free up of the both upper and lower poles, and then the control over the renal vessels and vein. The lean is demarcated with the diathermy, and at the same time it is excised, and during the perioperative, if there is any opening of the collecting system which is sutured, and then after that hemostasis is done, and depending upon the bleeding, if he need a drain or not, and then I will come out and write my notes.
Will you plan transperitoneal or retroperitoneal?
The planning is that again the retroperitoneal has a better access and less bleeding as compared to the transperitoneal, but transperitoneal has the more view.
Okay, during robotic surgery, which one is easier to do?
Yeah, I have never seen such, but I guess it will be that intraperitoneal.
Okay, and patient had uneventful post-operative improvement, and his histology came as 3 point. Okay, we'll stop there. So the histology is 3.3 centimeters, clear cell RCC, margin negative, and how are you going to follow him up? For example, just to complete.
So it will be the Leibovich intermediate risk, and then he will follow up will be the CT scan 6 monthly in the first year, and then every year for 1 to 2 years, and then after 5 years it will be the 2 yearsly. And okay. My follow-up will be the examination, and then with the bloods, which include FBC, UNE follow-up.
Okay, good. That's well done. You have brought in the cancer specialist nurse. That's very good, and try to bring the names like Macmillan nurse. In the first scenario, we haven't brought in the Macmillan nurse, which is very important. You are slightly more lenient towards the radical nephrectomy. There is no need to say like this: fit gentleman, opposite kidney normal, and the lesion is such a small one. It's a T1A. So partial nephrectomy has very high success rate. Your statements like partial nephrectomy, in comparison, the radical nephrectomy has better tumor clearance and better margin negativity. They're all not very true. There are some very good units, and our experience in partial nephrectomy has improved a lot. So I will say I will directly give partial nephrectomy option for this patient, and I don't even bring in radical nephrectomy, or maybe I will bring in radical nephrectomy as maybe like a second choice in case if patient is not convinced, but you need to sell partial nephrectomy for him. And the other thing is, I will not accept robotic partial nephrectomy as a gold standard. That's a little bit of a very big name you said. If you take BPH, even though we have holmium, enucleation, and various minimally invasive procedures, still TURP is the gold standard. And we are very confident that in future, holmium enucleation or any anatomic enucleation of the prostate will become gold standard. There is no doubt in that, but not until now. So similarly for partial nephrectomy, I will not say robotic as a gold standard, but robotic is a good method, and it is feasible, and it gives better outcome, like better surgeon related comfort and ergonomics, and also maybe there is very marginal improvement in the blood loss and early ambulation and discharge. But oncological outcomes, surgical margin positivity, there is no big improvement in robotic partial nephrectomy. And also there is a learning curve, as you said. So gold standard is a little bit a big bite to swallow.
So
Okay.
what will be the gold standard? I would say must
You
laparoscopic or
don't,
the open one?
open will be still the gold standard, but you don't have to really get into a problem by unnecessarily mentioning that
Oh, yeah,
term
yeah.
gold standard, because there is no real gold standard, and definitely robotic is not the gold standard.
Thank you.
It's like saying robotic is the gold standard for the radical cystectomy. Yes, we can do radical cystectomy. You can do neobladder reconstruction with robotic, but they're all not gold standard. They're all
Yeah,
feasible and available in high volume centers. Okay.
yeah, yeah.
Otherwise, good flow. I'm happy that you brought in the Libovich scoring system and various scoring system. That's very important. And so it can happen. Sometimes you may have MRI of the renal malignancy. So just why particularly I brought this picture to discuss the MRI images. I'm not sure how many of you have had the opportunity to discuss the MRI images.
Yeah.
Okay, can we discuss the next scenario? Who is next?
I'm next. Thank you.
Okay, good. Your time starts now. You have a 71-year-old gentleman presented with fever and unwellness to A&E. He was admitted, and he was treated like a septic patient under the care of the medics. The CT scan done as a part of sepsis screening showed uh, left renal mass lesion and also a possible lesion in the right kidney, and hence you are called for the opinion. He's very sick, fever with deranged bloods, increased low platelets and increased WCC, and with a shift to neutrophils.
So I'll see this gentleman as soon as possible in the ward. I will make sure that he is resuscitated according to the ALS protocol, and also the sepsis 6 bundle is already in place. I'll take a focus history to see whether this mass is already known, and whether he has got other symptoms like hematuria, back pain, loss of weight, loss of appetite, and other constitutional symptoms. I will review his past history, the medications he's on. We'll look for any risk factors like any features of obesity, hypertension, and any family history of any renal malignancies. I'll review his. I'll move on to the examination in the presence of a chaperone. Review his observations, and examination wise, I'll see his BMI and performance status, an examination of left loin to see if that mass is palpable, examination of abdomen external genitalia and DRE, and a focused neurological examination. Moving forward, I will review the charts and see the hemoglobin level, calcium, liver function test, EGFR, creatinine, and we'll review the CT scan myself and see if it is a contrast enhanced CT scan or a non-contrast one, and see if there is enhancement of the lesions in the CT scan. This will be my initial approach to him.
Okay, why specifically you're looking at hemoglobin and calcium? What is happening with him?
So I think this could be either a primary renal tumor or on both sides, or it could be a metastatic renal tumor with metastasis from the other kidney, or it could be a metastasis from another primary. So I want to see his performance status and the calcium, so that if it is a metastatic tumor, I can better risk categorize him.
Okay, so this gentleman present with fever and raised inflammatory markers, and he has got hemoglobin at 17, and he also has hypercalcemia. What is happening with him?
So I think this could be the paraneoplastic syndrome of renal cell cancer. The most commonly found one is anemia. However, we can have features of polycythemia and hypercalcemia, and also liver dysfunction, also known as Stoffer syndrome. This points towards like a aggressive type of renal tumor with paraneoplastic presentation.
Okay, his renal functions were normal. Why increase in hemoglobin happens in paraneoplastic syndrome?
That's because of the production of erythropoietin by the tumor cells. Yeah.
Okay, so you're ordering a CT scan. I'm going to share the pictures now. You can go through with me. Are you able to see the pictures now?
Yeah, I can see that.
Okay,
so this is the axial section of a CT scan.
Yeah, we're going from top to bottom.
So the chest appears to be normal in this axial section. Coming towards the liver also appears to be. I can see the left kidney now, and it's a really big mass replacing the left kidney, and there's a mass lesion in the right kidney as well. This is a non-contrast CT scan. And coming down, I cannot see any big lymph nodes in this section, or I have to review it again. And coming to the pelvis,
Okay, let us see the coronal sections.
So this is the coronal section of the abdominal pelvic CT scan, non-contrast, going from anterior to posterior. I can again see the mass in the medial aspect of, supromedial aspect of the left kidney. And I can see the renal vein on the left side, single artery it seems. Right kidney, also there's a mass in the upper pole. I couldn't see any abnormal.
Okay, there are normal veins and no lymph node involvement. Liver and other stagings were normal. So what are you going to do for him?
So for him, I will discuss this CT scan in the MDT. The options I think the MDT will discuss are one, to take a biopsy from the kidney on the right kidney, the mass on the right kidney, and see if it is a renal cell cancer or if it is like a metastatic lesion. And if it is proved that it is metastatic lesion, sorry, I have to review the CT scan of the chest as well to make sure that it is clear. If it is clear and if it is only these two lesions, it could be either two primaries or it could be a metastasis from the primary on the left kidney. I think we have to go ahead with the biopsy and see what the histology of the lesions are.
Which one you will biopsy first?
I will biopsy the his kidney functions are normal, so I will biopsy the right kidney first and see if it represents a renal cell cancer.
Okay, right kidney biopsy shows clear cell renal cell cancer, Foreman grade 2.
Yeah. So, all right. So his options are one, because once he is stable, then he has to undergo a radical nephrectomy on the left side and a possible partial nephrectomy on the right side. I recognize that this is a very difficult situation, because doing the surgery can make him almost anephric. So we have to involve the nephrology team, and also I have to discuss with the oncology team to see if starting a TKI inhibitor can decrease the size of the lesions and whether it can improve the surgical options, and also to have a discussion with the radiology team to make sure that the lesion on the left side is characteristically increasing in the contrast. So that will be my approach initially for him. I'll see him again in the ward and make sure that he has recovered well. In the presence of a cancer nurse specialist, I'll tell him that this appears to be like lesion. I mean, the left kidney lesion is very big. It's very difficult for us to preserve the kidney on the left side. However, once that is done, we can try to go ahead with a partial nephrectomy on the right side. However, it is a high-risk procedure which can make him anephric. So I'll discuss these options with him and then take the scenario forward. Thanks.
Okay, so how will you plan his surgery?
So once he is recovered from the current problem and once his paraneoplastic symptoms are controlled, I'll discuss this with the senior anesthetic colleague. I will involve the nephrology team. The initial plan will be to go ahead with a left radical nephrectomy and then give around 6 to 8 weeks for him to recover from the surgery, and then later go ahead with a partial nephrectomy for the intention with a partial nephrectomy on the right side, but bearing in mind that it might end up in a radical nephrectomy, and I will involve the nephrology team beforehand itself.
Okay, you're doing left-sided radical nephrectomy. The histology came as leiomyosarcoma. Will it change your plan any further?
It will not, in the sense that still it is a clear cell RCC on the other side, which has got which will progress further, and it can be life-threatening as well. So we have to again go ahead with the partial nephrectomy on the right side.
Okay, good. Well done. It's a challenging scenario, and I purposefully don't want to cover the same scenarios which we did before, because we had a quite decent and detailed discussion of renal cell cancers at least twice. And you may remember once we did complete 1 hour on the full theory of the renal cancers. So I really searched and tried to get some CTs which were not covered in the past. So this is a left-sided renal or it's a left-sided retroperitoneal leiomyosarcoma involving the left kidney. That's a correct term rather than saying renal cancer. I will try to share the picture again and explain the other features. You guys able to see the picture now, isn't it?
Exactly.
So the thing which points more towards the leiomyo cancer or any retroperitoneal cancer is, if you see, even though the mass is involving the left kidney, we can appreciate that the mass is more prominent and it seems to be pushing the kidney down. Okay?
Yeah.
When the actual kidney is pushed down, that means the mass is more of like a suprarenal in origin and then pushing it down. It's a very important finding which will help you even in adrenal lesions. So the same thing could be a adrenal lesion and pushing the kidney down involving the left kidney. Okay, so if it is a renal cell cancer, you will be seeing more of like a kidney present here and with overall increase in the size in all the directions. And it's much easy to recognize in coronal and sagittal than compared to the axial picture. So you can see that the lesion is more of suprarenal and pushing the kidney down compared to the right kidney, which usually is lower in position. The left kidney is much more pushed down. I mean, not picking up this finding will not jeopardize the results. I'm very happy for you to take this as a large left-sided renal tumor with small right renal cancer also. There is no problem with that, and I'm happy with your decision of doing the biopsy on the right side, because I think your aim is if we do the biopsy of the right side, if it comes positive, it indirectly means that the main lesion on the left side also could be a renal cancer. That's your working plan, isn't it?
Yeah, exactly.
Yeah,
And
but your main aim is to make sure that the right side is metastasis or not. That won't be answered. By having a biopsy of the right kidney coming as RCC, you can't
mm,
say whether it's a primary RCC of the right kidney or it's a metastasis from the left kidney RCC. Okay?
yeah, that's true.
So the idea of biopsying the kidney will not answer whether it's a synchronous tumor or whether it is a metastasis from the other one. Let's be very clear in that. Okay.
Yeah.
So if there is a renal tumor with a metastasis to say liver or lung or something where you need to prove the metastasis, yes, doing the biopsy of the metastatic site is useful because you're not expecting the renal cell cancer tissue to be present in the liver or lung. So when they are present, it is definite metastasis. But if you're discussing synchronous renal lesions, just by doing a biopsy, you can't say it's a metastasis or not. So that's where I expected you to be quite clear. But again,
Mhm.
there is nothing wrong in doing a biopsy of the one of the lesion. But
Mhm.
doing the main big lesion is also equally a good choice. Okay.
Oh,
So there is
because
no need to do the right kidney biopsy. The left kidney biopsy also will give you the same answer. And of course, it may give you an answer about the leiomyosarcoma, which may prevented you in traveling in the route of TKIs or any other immunomodulators pre-op, which will save you a lot of time. Patient is not going to respond to renal TKIs for this lesion.
sure. Yeah. Okay.
Okay.
Thank
Yeah, so the take home message from this scenario is rarely bilateral renal tumors are possible. When you're
you.
taking the biopsy, you can easily go for the bigger lesion. That is, or whichever lesion is easily accessible without having any bowel coming on the way. And I'm happy with your planning of involving the Macmillan team, involving the oncologist and nephrologist. Be strong in paraneoplastic syndrome. I think we discussed this before, and
Mhm.
the reason for increase in hemoglobin is erythropoietin like materials produced by the kidney. Okay, it behave almost like erythropoietin. They are not actually erythropoietin. Okay, and you have done the paraneoplastic part well. Yes, I will go for the left-sided radical nephrectomy. We can treat it as a renal tumor as long as the histology is not available. But if somebody can pick this up, like there is a possibility that the lesion seems to be more of suprarenal in origin and kidney seems to be pushed down. You can see at some areas the whole kidney is maintained. That will give you a very big brownie point. But if somebody is not picking up, it will not jeopardize the results. Still, you can get easily 7.5 and 8. And but little bit carefulness, little bit observedness, especially because of adrenal possibility, that will give you more marks. Okay.
And was the right thing to say biopsy of both sides, or
We can say biopsy of the both sides, but I will say go for one side first, because by doing biopsy of both sides, if patient gets into bleeding, then we don't have a normal kidney to support.
yeah.
So in this scenario, biopsy of the left kidney, and if the left kidney shows leiomyosarcoma involving the retroperitoneal tumor specialist, or because it's an entirely different specialist, and of course you need to be there because the kidney also needs to come out, and so that's how it has to be taken up. So biopsy of the left kidney first, and of course you can do biopsy of the right kidney. Nowadays the biopsy pre-partial nephrectomy is becoming much more widespread used because it gives us an histology to prepare the patient, and yeah, especially when you're doing RFA, cryo, or any other minimally invasive things, it's nice to do the biopsy and do the lesion ablation in the same time.
Perfect.
Okay,
That's great.
so this
Understood.
patient needs a left-sided radical nephrectomy, and then once he is recovered, we need to maybe even restage to make sure that the right lesion is amenable for partial nephrectomy. As you said, we need to consent him for dialysis, and we will try to do partial nephrectomy and preserve as much of right kidney as possible. But even if we preserve the right kidney, he may end
Mhm.
up having dialysis because the renal reserve won't be enough.
That's perfect.
Okay,
Thank you so much.
good.
Great.
So can
Thank
we go for the last scenario?
Sorry, can I ask one question, Mr.
Yeah.
G? So we gone for the left radical. Cannot we do at the same time right partial, or we should be do at the later stage?
It's always better to discuss, at least from the exam point of view, in two different stages. In
Mm.
practical life, of course, if we are in a tertiary teaching center, there is a role for one side radical nephrectomy and opposite side partial nephrectomy, but it's more for theoretical reasons. But the safest thing is to do the left radical retroperitoneal resection of this lesion with the kidney, and allow the patient to recover, and that gives a time for the right kidney to go for compensatory hypertrophy because of the absence of the left kidney, and a marginal 4 to 6 weeks time will be good for the patient to recover, and then we can go for partial nephrectomy of the right side.
Okay. And is there a role of DMS scan if there will be a bilateral lesions?
Yes, there is a definite role for DMSA that you can do anytime, and preferably to be done as a baseline so that you will know what is the relative renal reserve for the right kidney. You can even mark ROI, radius of interest 2, on the right side, so that you can mark the upper pole and lower pole, so that the lower pole which you are going to preserve, you can ascertain the amount of tissue or the function remaining.
Thank you. Thanks.
Okay, we will start the last scenario for today. You ready?
Yes, I'm ready.
Good. The time starts now. You have a 45-year-old gentleman presented to your clinic because his scans done by the GP showed 1.5 centimeter right renal lesion, and he's very concerned because his mom had left radical nephrectomy due to RCC, but the surgery went well, and mom is still alive and healthy. So he is very concerned about the possibility of inheriting the RCC from his mom. So you're seeing him in the clinic.
Yes. I will see this patient. I'm seeing this patient in the clinic as a 2-week wait, and I will want to confirm a few things, which include history of, if he has felt any loin mass, loin pain, hematuria, any weight loss. I want to also find out why he had the scan that picked the lesion. I want to know if he smokes, any history of obesity, hypertension. From the history, he's got family history of cancer. I want to assess his general comorbidity and drugs that he's taking. I would then examine him in front of a chaperone. After taking a consent, I will check the supraclavicular lymph node, check body mass index, check abdominal examination for any palpable mass or other abdominal mass. I'll examine the external genitalia and do parectal examination. And then this scan he had, I want to believe is an ultrasound scan. So I would then cancel him for a CT renal characterization scan. And then I'll do baseline renal function test, full blood counts, checking calcium, and reviewing with the results.
Okay, his baseline blood investigations were normal. He is asymptomatic. His examination findings were normal. No specific lesions or defects noted. He is asking you about the propensity or possibility of the renal tumor inheritance from his mother. How are you going to explain to him?
So I would explain to him that there's about 5 to 8% genetic predisposition in renal cancer, and usually with genetic predisposition, the presentation is earlier, usually in the less than 30 years. So I will say it's a small chance. It's a small possibility, but we will take this on its own merit.
Okay, what do you know about hereditary renal tumors?
There are several genetic linked hereditary renal tumors, one of which is von Hippel-Lindau syndrome, Bertolt-Dube syndrome, tuberous sclerosis, and hereditary papillary cancers, and hereditary renal cell leiomyomatosis. leiomyosarcoma, and renal cell cancer.
Okay. Explain any one of them.
So von Hippel-Lindau syndrome is a syndrome that is caused by mutation of von Hippel-Lindau gene on short arm of chromosome 3, and it leads to dysregulation of hypoxia inducible factor alpha, which causes the tumors in the brain. It causes cerebellar hemangioblastoma, retinal angioma, pancreatic tumor, and then there could be epidermal cyst as well.
Okay. And is there any relation between the recent innovations in the treatment for the RCC and the von Hippel-Lindau syndrome pathway?
With von Hippel-Lindau syndrome, they are prone to having renal tumors. So with recent innovations, they are usually just monitored. The chances of having significant cancer is when the renal tumor is above 3 centimeters. So they can be put on surveillance. They can be managed with ablative therapy if there are small tumors, except if it's bigger than 3 centimeters, for which a partial nephrectomy will be required,
Okay.
or the radical nephrectomy.
Okay. This patient had a CT scan. Unfortunately, I don't have the scans with me. It is reported as Bosniak 2F cyst. What do you mean by that?
So Bosniak 2F cyst is a cyst in the kidney that's got multiple septations, sometimes more than 3 centimeters, a bit of thickened wall of the cyst, some calcification, but there is no demonstrable enhancement. So it's more of a complex Bosniak 2 cyst. It's got about 20% chance of becoming malignant renal cancer, and this will require regular follow-up. EU guideline has recommended follow-up for at least 5 years.
How are you going to follow him up?
So I would the follow-up will be by regular scanning of the kidney to look for any interval changes. So in my practice, I do CT scan every 6 months. But sometimes if these cysts are better assessed on ultrasound, I can be doing ultrasound scan every 6 months as well.
Okay, this patient had a follow-up CT in 6 months, which showed an increase in size, and now the lesion is 3.6 centimeters, and no major difference in enhancement noted. What will you do?
So I'm concerned this is progressing. I will have a discussion with this gentleman after discussing the new CT scan in MDT, and then the discussion will be in the presence of a cancer nurse specialist. This is clinically stage T1A tumor, so I would cancel this patient because he's 45 years. I would expect he's got a good performance status, so I'll cancel this patient for partial nephrectomy.
Okay, he wished to have some alternative minimally invasive methods rather than partial nephrectomy. What other options available for him?
So the other option will be to continue active surveillance, which I wouldn't recommend considering his age. He's also got options of cryotherapy or radiofrequency ablation. I would explain to him this. I've got about 20 or 25% increased risk of recurrence when compared to partial nephrectomy.
How the cryotherapy works?
Cryotherapy works by giving 2 cycles of freezing and thawing using liquid nitrogen or argon to create ice crystals within the tumor cells. And the temperature is less than minus 20 degrees Celsius. It can be given percutaneously or laparoscopically depending on the location of the tumor.
Okay, and between cryotherapy and radiofrequency ablation, how will you explain the pros and cons to the patient?
So the pros and cons, the difference in them is just the mechanism of action. So with cryotherapy, it's formation of ice crystal within the tumor cells, while radiofrequency ablation heats up the tumor cells to above 850 degrees Celsius to destroy it. The evidence has shown they are both comparable in terms of oncological outcome, but they are inferior to partial nephrectomy.
How the radio frequency ablation works?
Radiofrequency ablation was by generating heat within the tumor cell using radio frequency waves. It causes hypothermia up to above 50 degrees Celsius and then causes coagulative necrosis of the tumor.
Okay, so this patient agrees for partial nephrectomy. You are doing a robotic assisted partial nephrectomy, and intraoperatively it is slightly difficult to identify the tumor since it is intraparenchymal. What options you have intraoperatively?
So intraoperative ultrasound scanning can be used as adjunct to the procedure. So it helps us to delineate the location of the tumor so that we can make appropriate surgical resection.
Okay, his histology shows, okay, we'll stop there. I'll just complete the histology. His histology shows 3.8 centimeters clear cell renal cell cancer with Foreman grade 2 and margins negative. And so how are you going to follow him up, for example?
So the standard of care is surveillance, and the surveillance will be with CT scan as per new EAU guideline 2021. Foreman grade 2 PT1A appears to be in the low risk as per label which. So that will be CT scan at 6 months, at 18 months, and at 30 months, after which I will do in 2 years following that.
Okay, very good. We'll stop there. I purposefully tried to bring in some questions on the radiofrequency ablation and cryotherapy because sometimes these will be covered even in the technology table, but it's nice to bring them here so that we are completing everything. Again, nice flow, no problem with communication. You're quite clear in what you're doing, and you're quite clear in giving importance to the partial nephrectomy rather than the other two methods, especially when you come to the small renal masses, especially for young, fit individuals. And I'm happy with your explanation of the Bosniak type 2 cyst and the follow-up protocols. And I purposefully touched on the hereditary renal cell tumors because it's a very boring and topic where you need to really mug up a lot of things, but there is a good possibility you may be asked in one table. If you quickly answer that like how you did, you will progress into clinical part, which is much more good, easy things to discuss with a lot of interest in the clinical surgical outcomes. So please be very confident on the theory of the hereditary renal tumors and how those genes have implicated in the immunotherapy and the various immune modulators pathway where they are coming in the VGF pathway. Very rarely, sometimes examiners may ask you to draw the pathway, and if you're able to draw with some labeling of where the sorafenib and sunitinib and bevacizumab and all those mTOR, where the mTOR comes into play. If you can draw the chart, which will be very useful. I'm sure you all have access to the chart. If necessary, I will post it in the WhatsApp group. Yeah, I'm quite happy. Nearer to the exam, fantastic preparation from everyone. Macmillan nurses were not brought in by at least 2 or 3 of you. It won't make a big difference, but it's nice to stick to the basics. And yeah, we've discussed everything up to the robotic partial nephrectomy. And yeah, any questions before we conclude?
Yeah, what's are the recent innovation you asked in the VHL?
No, it's like innovations in the sense like in the pathway, we are just trying to get the medicines for everything. Like for example, mTOR pathway, everolimus. So that's the main thing, and it's not more like an innovation. It's more of like
Right.
how we identified the pathway, what is the hypoxia inducible factor alpha and beta, what is happening normally, and if you have VEGF inhibitors, how it blocks the hypoxia inducible factors and how it results in improvement. So that difference you should understand. And some specific drugs like sunitinib, hand-foot syndrome, what is the relation between the hand-foot syndrome and sunitinib. So specific side effects, if you understand the relation of the pathway, you can even understand the side effects also. It's very oncological, but there is a good possibility if you have an inoperable tumor, they will discuss the upfront VEGF inhibitors or the newer immunomodulators like pembrolizumab, etc. For example, the Anish scenario, when you're doing the histology, you should stay in for PDL1 so that that will be more suitable for any future immune modulators in the follow-up. Okay.
So can you please post the chart you have on, it will help us to just go through, please. Yeah.
Sorry, I'm not getting the question.
You have some chart about these pathways. Can
Yes.
you post on the
Yes,
please,
yes,
yeah?
yes. Of course,
will
I will give a chart. It's a very simple
you.
chart including the hypoxia inducible factors
That's
alpha
good.
and
That
beta.
will be great, sir. That will
Yeah.
be great. Okay. Again, I will be thankful to you, Mr. D, for your hard work, and it's very dedicated.
No
throughout the
worries.
slides. It's really, really helpful in the exam scenario. Yeah, yeah.
Don't
thank you
worry,
very
we
much.
will do more. Yeah. So I
Thank
will conclude the session and then we'll discuss further. If there is no further questions in these 4 scenarios, thank you for all 4 of you to come in. We will do some more scenarios and we will possibly discuss pediatric scenarios tomorrow. By now, we call the class dismissed.